Good morning. My name is Claire Clark and I'm from Dynam. We are supporting Highlands and Islands Enterprise to deliver this event today. It's great to have you all join us for this Business to Healthcare webinar, which is part of DataFest 21. A very warm welcome to you all. Before I pass you over to Andrea, I'd just like to spend a minute explaining how we will run today's webinar. Shirley from Business to Healthcare will host the first half of this webinar with a short group discussion. Then we will pass over to Adrian from Business to Healthcare for the second half. At the end of both Shirley and Adrian's discussion, there will be a chance for you to ask any questions you may have. As an audience member, you are automatically muted, but you can use your question box at any point throughout the webinar and we will pick these up during the Q&A. You'll also see an icon called the raised hand icon, and during question time, if you've got a mic and you want us to take you off mute so you can speak directly with our panel, then just click on the icon and we'll get you connected. And finally, we always want to promote knowledge sharing and collaboration, so we do record every session. We will, of course, share the recording after the event, so you can watch again or share with anyone else you think may be interested. That's all from me just now, so I'll pass you over to Andrea, who will introduce today's speakers. Andrea.
Hello, thank you very much, Claire, for the introduction. So my name is Andrea McCall, and I work in the Life Sciences team at Highlands and Islands Enterprise in Inverness. I'm delighted to welcome you to our webinar today that we're hosting as part of the DataFest event series. And I'll just change on to the next slide so you can see a little bit what we're planning today. So we have two short group discussions planned, 30 minutes each, with 4 small companies who are involved in data and health. And all companies here today are supported by our Business to Healthcare program and receive advice from our coaches at Digital Healthsense, and it helps them to navigate the complex health and care landscape. And 2 of these coaches are here today with us, and they're hosting our discussion today, Shirley and Adrian. So before I hand over to Shirley for the first discussion, I just wanted to quickly acknowledge our funders of the Business to Healthcare program, the Inverness and Highlands City Region Deal and ERDF. So Shirley, before I pass over to you, so you can start off with the discussion around diabetes. Just to say that Adrian will then cover in the second half a little discussion around moving towards remote healthcare and delivering services in a remote manner. So Shirley, over to you.
Thank you, Andrea, for the introduction. As Andrea just mentioned, my name is Shirley Gaynor, and I am one of the coaches working on the Business to Healthcare program. And over the last number of months, we've been supporting 2 businesses in particular who are working on some diabetes work. And so we're really excited to talk to them today. So the first that we'll be speaking to is Eva, who is the Managing Director of Dignio here in the UK, and Celia, who is CEO of Retina Risk. So before we just start the discussion, I thought it'd be a really nice opportunity for Eva and Celia to tell you a little bit about their businesses, and then we can go into the discussion. Eva, would you just like to introduce yourself?
Great to be here today. Thanks a lot, Shirley. So my name is Celia Jónsdóttir, and I'm the CEO of Retina Risk. Do you want me to actually go into introducing the company now, or was it just to introduce us? Yes.
Yeah, that would be perfect.
Absolutely. So basically, we are a health tech company founded by doctors and scientists here in Iceland with the aim of transforming the future of healthcare by providing personalized care based on individualized risk assessment. So with this approach, we basically believe that the right patient will be receiving the right care at the right time. Our initial focus is on diabetic eye disease, which is one of the leading causes of blindness actually in the world today, but more importantly, can be prevented in over 90% of the cases with early detection and timely treatment. So by leveraging the power of technology and data, we want to prevent basically millions of people around the world going blind unnecessarily. We have built a clinically validated software platform which is centered around our proprietary algorithm that accurately calculates the risk of sight-threatening diabetic eye disease based on the patient's clinical data points. So basically, with retina risk, you can stratify an entire cohort and identify high-risk patients who need more intense care to prevent vision loss instead of the current one-size-fits-all approach. So we really believe that using data to build algorithms and artificial intelligence for prevention and personalized medicine is the future of healthcare. And based on commonly available data points, retina risk can basically empower diabetic patients, allowing them to monitor their risk and take the necessary steps to prevent vision loss. Serve doctors as a decision support tool to identify the high-risk patients and optimize the clinical outcomes, and enable healthcare systems to streamline eye screening programs to make them more efficient and cost-effective. So really our overall objective is to use data, information technology, and individualized risk assessment to enhance clinical outcomes, motivate patients, and increase efficacy in the screening systems. I'm going to stop there.
Perfect. So that's great. Thank you so much. Eva, would you just like to tell us a little bit more about Dignio?
Yes, sure. I'm sort of glad that I had a bit of a tech mishap, because I've heard wonderful things about Shirley's company and product, which is, sounds like a really fantastic tool for diabetics and for the system, which is there to keep people well and also to prevent deterioration and to have powerful, credible and valid tools to support the process of diagnostics and support of recovery and staying well. Dignio is an original Norwegian company. We bring a mature and assured technology solution, which is connected care platform. Our connected care platform has been in use since 2013 at scale in Norway. We are the market leader, present in 90% of the Norwegian territory. We have multiple exemplars in the UK. We've just started working with the B2Hc program to also have exposure in Scotland. We bring a solution which is a software as medical device with third-party medical devices for monitoring vital signs. And we have two versions of the app, one for self-management and the other one for care professionals. So you end up with a dual feed of the world as it is according to the person who has been diagnosed with an illness, but also according to the professionals. And then both feeds go to the clinical care team. And our focus, much like Shirley's company, is about detecting deterioration, keeping people well, and giving them powerful tools to really stay well, to be educated about what makes them better, what makes them worse, and to be a really active part of the treatment and prevention process. So they are not dumped with technology, they're actually part of the connected care pathway. And with the current reforms in the NHS and the focus on integration of care, which traditionally has been fragmented, we are really optimistic in terms of impact that we can really exert for the UK patients.
Eva, thank you so much for that, and I think that's really helpful. And I think certainly one of the themes that's coming out from both of you and both the companies is how we think about putting data and information in the hands of initially the patient to be able to self-manage. And so I just wonder if you could just perhaps talk a little bit more about how you're doing that, and I guess some of the impact that's having by the patients having the information directly in their hands and how it's helping them.
Sure, absolutely. Well, I think that exactly like Eva says, I mean, patients are just in general becoming more knowledgeable and actually active participants in their wellness journey. And I think that is obviously a really good thing. This is happening as health data becomes increasingly available through the wearables and other means. Your Apple Watch, Fitbit, everybody has this, or many people have these, and many, I think, have actually more information that they actually can digest and actually use in a useful manner. And I think that is kind of like part of what we are trying to do. So we're really empowering the diabetic patient to actually make some meaningful use of these data points. So allowing them to actually assess and monitor the risk, and actually link, how the lowering of blood pressure, lowering of blood sugar, which is kind of one of the key risk factors for diabetes, can be linked to actually, be it your lifestyle choices, be it the nutrition, physical activities, and these things. What we have emphasized is raising awareness of the diabetes complications, Sadly, often people are not aware of that diabetes is one of the leading causes of blindness and that you can do a lot to prevent it. So we are really kind of like using data to help people to better understand and making it more easily visual, so that you can actually understand not just some numbers on a white paper, but actually putting it into a color coded that if you are on red, it means that you normally stop and you think twice, I need to go and see my doctor, there's something wrong. So try to kind of like use the data to make it somehow meaningful for the patient. So we really believe that we are kind of like making now cutting edge science available to the global diabetic population of 500 million people. And I think that is extremely valuable. And I'm sure that we're going to be seeing much more informed and healthier patients in the future.
I think the point that Celia picked up about the volume and the nature of the data that both patients and healthcare professionals are swamped with. I think the dangers of digital tools and AI tools are that sometimes organizations and systems try to run before they can walk. And they don't look at the features of the solutions they're bringing in. They either create their own or they bring in solutions from the market. But one thing they do not consider is the full life cycle impact of the data swamp on the patients and the clinicians. So the feedback we hear on the ground is that patients get data which is meaningless to them. So they stop interacting with the digital products. And the clinicians get data points which are of zero interest to them, and they feel that it's actually creating more work for them rather than less. So I think it's something to be mindful that when we are introducing tools that are supposed to empower patients, that those tools are fit for the purpose and they do not create more burden and are actually utilized in reality, not just sound good on paper, in theory, on contract, but are actually then vetted, that people are using them and are satisfied with the outcomes. And the other thing that occurred to me is this support for self-management. So the traffic light system is something that everyone intuitively understands. It's now present on food products, on everything, because you're quite right, Celia, where it says red, you sort of stop and think. And that is a really powerful psychological tool to motivate people to have a deeper reflection about, oh, hang on, what am I doing? Orange, maybe I can sort of self-excuse, but when it gets to red, I should really do something about it. And one of the features we've introduced is, or we've had for a while, it works really well for patients, is a dynamic self-management plan, which basically is subject to the data flowing into the system. It tells them, you have now tripped into this zone. And also the clinicians can move them between the sort of red, amber, green, and subject to which zone they're sitting in, it gives them immediate instructions that now you need to change your behavior, now you need to change what you're doing, now you need to take extra measurements, and then it can trip back to the de-escalate to a lower grade. But the whole point of it is that digital tools are a really powerful option to support people, to help them stay stable and well. And what they do for clinicians is they allow them to, when they're constructed well, they allow them to prioritize the individuals, the non-compliers, the ones that don't know how to use the tool, the ones that are a bit worried, that need a bit more hand-holding. And you'll always have I think there's a degree of naivety that, you know, digital tools will replace clinicians they want. It's about streamlining their workload. It's about giving patients additional support. And you will always have a percentage of population who are unable to use digital tools or who require extra assistance. And you need to build that into the system, that there's that capacity to support the ones who will struggle. But majority of the patients are quite capable of using smart technology. So I'm very optimistic in terms of diabetics. It is such a vast group. As we know, the burden of the disease is increasing globally with the adoption of unhealthy lifestyles. Unfortunately, as people's incomes go up in low and middle income countries, the knock-on effect is increased diabetes risk. And it's a disease which has lifelong consequences. So well worth looking at technologies that can make a difference, because the impact on the system and the budgets and the healthcare availability is massive.
Yeah. And Eva, you bring up a really interesting point there around it's great that we have all this technology, but obviously a big piece is actually, when we're thinking about self-management, is engaging our patients in the technology. And I guess you know, as you said, there's so many different applications out there and there's such a wealth of data, and, you know, we're all got these different apps going on. You know, how have you both approached so that you are engaging the people and they are taking on? You touched Eva briefly there on the fact that clinicians can see who has them, but what do you think it is about each of your apps that is saying to people, yeah, I want to partake in this, and I can see the benefit of it?
So with our solution, we really focused on paying attention to user friendliness at both ends, because there are a lot of apps out there. You're absolutely right, Shirley, a lot to pick from. So one of the initiatives in the UK is something called ORCA, which looks to assess apps and to verify that they actually do what it says on the tin, because marketing is a very powerful tool and it can be easily bamboozled by the surface features and listings, etc. The difference is we have undergone ORCA assessments, so have other suppliers. And also in terms of user friendliness, we were determined to create a solution which is user friendly to both the clinicians, so they get the data they want, which is useful to their daily practice. And then at the same time, the patients get interface and the structure of the tasks, self-management tools that allows them to not feel, oh gosh, I'm being nagged again, but to feel I'm being supported. I get nice reminders. I have hardware tools which I can use without any hassle. You know, it's about demystifying, de-risking. Every time you put a barrier in front of a person, so for example, you give them a piece of kit and they have to do any pairing, I guarantee you majority of the people won't be bothered. They're just going, nah, can't be bothered. So it's all about understanding how a regular person who's not necessarily tech savvy, who maybe is frail, elderly, who maybe is someone who hasn't interacted with technology before, what are the things that can go wrong? And you still learn. So we learn on an ongoing basis, which is why we like to stay in really close contact with our clients and patients being serviced by them, because that's when you find out where your imagination has not stretched far enough and something has not quite gone as you anticipated it would be. But because of that, we focused on user friendliness at both ends, because I think with tools like Cilius and Dignios, the most important thing is to ensure that they're actually being used, because without the users interacting, you won't get the data sets. Yeah. And to ensure interaction, it needs to be simple to use. It needs to be user-friendly for both parties. Otherwise, they get abandoned.
Yeah,
I think this is really right. And I think kind of like the ORCA platform that you mentioned, I mean, I think this is exactly also where we are heading, because you're right, there are lots of apps and lots of digital platforms out there. But I think what in the future is going to distinguish is kind of like the clinical validation and actually the real evidence-based what they actually do, and that is actually where, for example, in the ORCA, how we have been rated very high because of the clinical studies, the clinical validation for many years. But I agree also that it has to be in the way that the patient understands and sees the value in it. I think for our app, both the ophthalmologist and endocrinologist see the value, and the patients themselves, because I think that blindness is one of these complications that people with diabetes fear the most. I mean, this is something that we can all relate to. Nobody wants to lose their vision. So I think that is really helping us in kind of like getting the app to basically the global population. I mean, we have already nearly 1 million downloads in 175 countries. So you can see this is everywhere in the world, that there is this dire need, and people are eager to get a better understanding and actually do something to save their vision. So what we also emphasize is that people with diabetes have a very busy life in actually managing their disease. So we also emphasize, I think many people look at apps as a game. They're used to kind of like measuring how often you use an app, like that this is Candy Crush or something like that, that yeah, I spent 3 hours on it. That's not what we see. We see this as a new generation of apps, that people are going to have this for lifetime. And that you are actually using this app to support your disease management, even if that would be maybe twice a month or once a week or whatever it is. It's not like the volume, but it's actually the value that it provides to the patient. And the healthcare providers actually as well.
I think the entire way the care is delivered needs to be remodeled, because there is scarcity of resources, there is a shortage of highly specialist professionals, and it's almost a question of streamlining the patients according to the need. And that's where solutions which allow people to self-manage, and you have a really good data set in terms of supporting the clinical decision in terms of escalation to different levels of care or different specialties. These are really powerful tools, and that is the way care has to be delivered. This is not digitizing care pathways is no longer a luxury, it's a necessity in modern times. And we need to overcome certain hurdles certainly within the UK, in terms of connectivity, in terms of culture, in terms of procurement pathways, and how digital tools are being purchased. but certainly it's not the future, it's today. And whenever we have conversations, when we describe what our tool, how it can support integrated care, it's not future. That's the way things should be happening today. You should have multidisciplinary teams looking at people's data sets. The patient themselves should see the full data set, see the trends, see what makes them better, what makes them worse, learn about their disease and have it demystified and be able to lead an active economic life. Because when people are really anxious about, oh, I don't know how I'm going to feel, tomorrow or 48 hours later, then they cannot really make a decision. Am I well enough to engage socially? Am I well enough to be economically active? Can I go to work? Whereas when they start to see bad weather makes me worse, oh, I've had a massive piece of cake last night, I know I'm going to pay for this today. And they see with their own eyes, yes, you've eaten a cake, and this is the knock-on effect, that persists for hours and hours and hours post-consumption. Then that it's a learning curve, and ultimately there's this push that individuals should be active agents in their healthcare provision, and they should take responsibility and part. And as I mentioned previously, there will always be a percentage of population that are not capable of doing so. But by enabling a vast majority to use the digital tools, you're releasing the resources to look after those most vulnerable ones who need the extra push from the actual clinicians and multidisciplinary teams.
Yeah, I think that's a very good point. And actually what that makes me think of that what we've seen with the caretakers, so actually with the doctors, like in our case, that we are obviously both talking to endocrinologists and ophthalmologists. And what is clear is that the ophthalmologists are mainly looking at the picture of the retina, the images, and the endocrinologists actually at the clinical values. So there is a certain gap there in between. And what we see often is that the ophthalmologist does not necessarily have all the clinical values, but the patient actually does have all of this. So I think that more and more we will see that the patient is actually the center of this. And I think this goes for more diseases actually. But these digital solutions can actually also help to bridge the, not necessarily gap, but kind of like have a bridge there between the different doctors, so that they, each one of them, are taking into account new data points to actually make a fuller, have a fuller picture of the patient to actually make a good decision for a better clinical outcomes.
Yeah, thank you for that, Sia. I think we've got just over 5 minutes left for us, and I guess I'm conscious that when I've spoken to both of you previously, we've talked about using our applications for how we treat patients today, but there is obviously this whole big piece on preventable health and actually how we're actually investing time to think about how we're using data to understand cohorts, thinking about future system modeling, and also, helping support commissioning needs better as we start to gather more data and have better understanding. And I just thought, just in the last 5 minutes, it'd be lovely just to hear from both of you how you're using that to then help us reduce this huge bill of additional, I guess the additional treatments that patients need as a result of having diabetes, and what we're trying to do to reduce that.
Well, sort of just looking at the commissioning trends, there's a great emphasis for digital products to also feed population health parameters and population health modeling and management of resources in terms of identifying bottlenecks in how care is provisioned on the ground and any sort of challenges to the smooth running of the pathways. And ultimately, the data that is gathered via digital tools needs to be available, and that's why NHSX puts a great emphasis on interoperable, and data cannot be sitting in silos. The reality is for 2021, for which month are we? September, beginning of, that is still happening. Data is sitting in silos, and those rich data sets should be enabled to be transferred elsewhere. The challenges for handling data and transferring it elsewhere are that the data is not always sitting on the formats which are transfer friendly. It's not, interoperability is a desire, it's not a reality in most places. And there's also obviously the great pushback that was had to sharing primary care data also gives you a bit of a flavor of what happens where a major change is suggested without consulting all the stakeholders. So I think there are various obstacles to overcome before those really rich, fantastic data sets from digital tools end up in a common shared resource, which can then feed not just population health management, not just resource management optimization, but also research as such, and some blue sky thinking and modeling and AI algorithms That would be the ideal case scenario, that data is traveling to multiple things. And from also what we focused on is servicing those, the vision you were talking about, Celia, that multidisciplinary teams have a single vision of the person. That's what we focused on, that you build the tool and you build the data gathering around the person, and those data sets are visible to whoever works with them, be it the specialist consultant, be it the social care worker, be it community nurse. They all see the same thing, and it should all be feeding into one single destination. The reality is, at the moment, our data would travel into different electronic patient records, which don't necessarily talk to each other. So depending on the level of care, they'll be sitting in different places. But the ideal should be all data goes to a single destination where the public feel it's safe, they feel it will not be sold for profit, and it is used for the common good.
No, I think this is exactly the case, and what we see is that we are starting with the eye disease, but there are obviously other complications for diabetes where the same applies, the same modeling. We know what are the risk factors. Risk calculation can help both the doctors and the patients themselves to make the right decisions to actually prevent these complications. And this risk modeling can actually be applied to other chronic diseases. So we are actually talking about a huge impact on healthcare. I would like to say now, but I think it's going to take a while. This is a bit of a transition. I mean, there's no question about it. But I'm very optimistic that we are going to be seeing this more personalized care, optimization of resources. I think that is going to be a tremendous thing. But also then kind of like for diabetes, linking this, that people understand, they're always being told, improve your lifestyle, but really to link it with, if you improve your lifestyle, you may actually save your eyesight. So it's not just like throwing it out there, do it, but because if you do it like this, you will actually see the results. I think that is a very important motivating factor. And I think the patient has to be a center in all of this, especially for diabetes.
Perfect, that's great. Thank you both so much for your time this morning. I know, Eva, you're going to be speaking in the next session as well. But I think if anybody's got any questions, then we will run them at the end of the session, and hopefully you'll both be still around to answer. So I am going to pass back, and thank you both so much for your time.
Thank you.
Very much indeed. So really enjoyable first session. Thank you very much. And obviously we focused in there on a very specific pathway, on a very important pathway, diabetes. What we want to do now is to broaden the discussion a little bit and talk about one of the big general themes that's been driving change and the use of data in the NHS and more broadly, which is about the drive towards remote monitoring, to helping people monitor their health generally, both actively with the sorts of devices perhaps that we've just talked about, but also using devices that are placed in their home as an assisted living environment. And in between those extremes, and Eva, you touched on this already, talking a little bit about the roles of various people in that data collection as well, because sometimes it's the patient collecting their data and using it, sometimes it's a carer assisting the patient, sometimes it's a remote device. So I want to talk a little bit more broadly about that. But before we do so, Eva kindly introduced her company and its role. Could I ask the pair of you, Simon first, perhaps to describe a little bit about your company, because we have an interesting mix of SMEs in this discussion now. So Simon, tell us a little bit about Findar.
Sure. Well, first of all, thank you very much for inviting me to the panel. It's a pleasure to be here. So Finder Technology is an Internet of Things asset tracking and monitoring platform. So what that means is that we can tag assets and track and monitor them anywhere in the world or within a building. And we can apply this to a number of sectors, but our most important sector is healthcare. And we work with two segments within healthcare. One is within hospitals, and the other is remote monitoring for patients in their home. So within hospitals, we solve a big problem in that the vast majority of hospitals use barcodes still to track assets and items around the hospital. Now, we all know that barcodes are very outdated, is an outdated form of technology, because what you do is you scan the barcode and you record where it is. But the problem is within a few minutes, normally, a nurse or a doctor or a porter has come along and taken that item away. So you've actually got no real-time information of where that thing is. And we saw in the pandemic, when there was a big rush for ventilators, everyone was scrambling around very quickly to find where they were, who had them, which hospitals, which hospital buildings, on which estates. And it was a bit of a mess. And this was a problem replicated around the world. So what we do is we tag the asset, the item, whatever it is, a syringe driver, a ventilator, a bed, and a nurse or doctor can look on their app very quickly and say, okay, I need this item instantly in this ward for this bed, and they know where it is. And that's the problem we solve in hospitals. For remote patient care, because of COVID, we know that a lot more healthcare is done outside of hospitals in people's homes, and we have the ability to track that those very expensive pieces of equipment that are being used in people's homes, so that they don't get lost, they're not stolen, they're monitored, and therefore we have a role to play there, and we have a number of clients in this space. Thank you. That's me in a nutshell.
Lovely. Thanks, Simon. And Iji, you happen to be in an organisation that has one of those expensive bits of kit that's flying around the place, sometimes to care homes, sometimes to homes. Tell us a little bit about what that is and how you use it.
Thanks a lot, Adrian. At the start, we had an Icelandic company, and then we had a Norwegian company. And well, glad to hear that it's not just myself that will be representing on the Eurovision contest tonight. We've got this afternoon, we've got Simon representing the British contingent. So Tech Health Solution is a British company, I'm glad to say as well. But essentially what we do is we provide remote diagnostic solutions for healthcare organizations. Our unique product at the moment is called the Techie Hub, and it combines hardware and a strong patient service software that connects patients on one end to clinicians on the other end. Now, due to the pandemic, we've all sort of experienced the surge in usage of video consultations all over the world. But there is that next step, which is the diagnostics. And I've been a clinician, I've been a doctor for over 23 years. Diagnosis from patient is a combination of history, physical examination, and use of diagnostic investigations. And so what Techie Health does is we add that diagnostic element as well as the physical examination element. And we're able to, we enable the clinicians to be able to do this remotely. So they don't have to physically be in the same room as the patients. A doctor can examine a patient anywhere in the world as long as there's an internet connection between both of them, and they can carry out up to about 10 different physical examinations on the patients. And you can imagine the vast amounts of information that becomes accessible to that clinician and is able to make more accurate decisions about patient care. Just to quickly highlight the various devices that are in our product. So we've got a digital stethoscope. We've got a high resolution video and still camera. We've got a no-touch infrared basal thermometer, an otoscope, and a tongue depressor attachment. Now, when I've said all of this, it sounds like we've got 4 or 5 different tools, but actually this is all in one. So it's a little mobile handheld device that is able to carry out all of these functions at the same time. We also have a portable ECG machine. We've got a portable lung function test machine. And again, these are all handheld, they're all wireless. So essentially, there are 2 or 3 ways in which we do this. One, we can send the kit devices to the patients themselves in their homes. And we're doing this with a pilot that we're doing currently with Imperial College, where we have parents of kids with chronic medical conditions who visit the hospital a lot, and we send the device to them. They'll have the device, they can connect to the doctor in the hospital, and they don't have to visit the hospital all the time. The second most common usage at the moment, well, the main usage rather, is in care homes. And as you can imagine, we're allowing this type of technology to be accessible to all individuals, not just people that are tech savvy. And so people in the care homes can have access to remote diagnosis solutions with the help of their carers, that is, without needing any particular learning on how to use technology. I think I'd better stop here.
Yeah, thanks, Ajay. No, I know you're passionate about it, so I know it's what you want to describe. So perhaps I could just pick up on that from you to begin with, Ajay. As a GP, you first and foremost, there's lots of governance challenges around the data that you're using, lots of different drivers for data, people asking for data from different directions, commissioners, patients, people in the practice. Could you tell us a little bit, and I'd love to hear from all of you about this, about the data that you're trying to collect and what some of the challenges are about that? What's motivating some of it? Is it the patient helping to drive the data that you collect, or is it driven from you as the clinician? Is it driven from what the commissioner needs to help you get this? What's the data you collect and what's the drivers for that is really what I'm trying to understand.
Yes, I mean, that's a very important question. I think as a clinician, primarily, data that I want to collect as a clinician is basically to arrive at a diagnosis for the patient. So the patient comes first for me. And like I mentioned earlier, you want to get a history. So you want to ask questions from the patients on the live scenario. You want to examine the patient. So you want to take information. Doctors are known to go around with stethoscope because we want to get some information from examining the patient. And then you want to carry out some diagnostic investigations. Now, all that data is needed to arrive at a diagnosis that would help you to profile the correct treatment options to the patient. The other reason why we collect data generally is for monitoring. I mean, Eva already spoke about remote monitoring, about what and how that can help individual patients, for example, patients with diabetes, etc. When you need to see what happened a few weeks ago, what intervention you've put in place, and what the outcomes are. So monitoring is good, is another reason why we obtain data. The other reason is research. And so this goes beyond just the clinician and goes beyond the patient. You need data for research purposes to be able to plan patient care, plan management, and essentially traditionally these are really the main reasons why we would like to collect data. Now, you mentioned government organizations, etc., also driving the need for data. Yes, there's that pool as well, because as you can imagine, the government organizations or the NHS organizations generally have limited resources. And so they need data to be able to plan the use of those resources. As a clinician, there's that pool because they want the data on the, more on the population dynamic side of things, whereas we as clinicians are probably more focused on the patient and what the patient needs in terms of the data. So you do get that little friction. And then there's the added bit of artificial intelligence coming through now. So now there's a pool for, there's a request for data so that we can build some form of artificial intelligence component into patient care. And this is interesting and is needed anyway. But I think just to answer the question, I think in summary, we probably still get to, we're still more on the patient end. And so in terms of what really drives our data and the type of data we need, we're still tilted more towards what is going to make the patient better, what's going to help the patient in terms of monitoring to get better. And then we then think about research because that's going on a population basis.
All right, so I get that. Thanks, Ajay. But I guess the other side of the coin is that you and all of you on this call need to get people to use your solution, and that's about persuading commissioners of solutions that what you've got has an impact, so not on the individual patient, but more broadly. So what are the commissioners asking for you? Perhaps I could go to Eva on this, asking you for in order to persuade them that what you've got makes a big difference.
I think the same is true across the board for different types of digitized products or services, which lead to generation of data and the data being deposited somewhere. And the current buzzword is data-driven decision-making. The data-driven decision-making appears in the clinical context, where you want to know what is happening to the individual, have any diagnostic tools, know what the trends are and what the changes are, and detect deterioration swiftly and intervene. But it's equally important for the commissioning angle and looking at population health level impact of the status as it is today, any intervention you introduce, and then what happens in terms of the system impact. So the data-driven decision-making appears as a buzzword across multiple contexts. Certainly from the point of view of commissioners, they want to have tools and interventions and services which make a difference to their people on a population level preferably. Obviously, when you're talking about, for example, ultra-rare disease individuals, that will not have an impact at a population level, but it will have massive impact in terms of gains from being able to treat an individual appropriately. So there are different perspectives. We focus on providing data that informs clinical decision making and providing data which empowers patients to self-manage. But as a knock-on effect, you have really rich data sets that can inform what is happening to your local population. If you institute any sort of changes across board, any interventions for specific groups, is it going to have any effect on the health gains? Are you dealing with health inequalities? Or are you still having a postcode lottery on the outcomes? So I think this sort of data-driven decision-making is the key word, and that is equally important for clinicians. We should be looking at what actually works in reality, the evidence base, but also for commissioners.
Simon, obviously your solutions are not so patient-focused as Eva and Iji, but nevertheless, the collection of data for your customers and its impact on the patients is a big issue for you. What sort of data are you being asked to collect, and how is it being used?
Sure. Well, there's two sides. The first is obviously location and timestamp. So we know that an item has been in a certain place at a certain time, and that's important for frontline healthcare staff and people that manage those assets within a hospital estate or in a remote patient care setting. We can also look at the condition of the equipment as well in terms of temperature, humidity, vibration, shock, sound, light. We can apply a lot of sensors to it. And in fact, we were asked about a year ago to start looking at oxygen levels within hospitals, because we can apply sensors to our technology, to our tags, to look at that as well. And the drivers are really twofold. One is productivity. So it's just making operations more efficient and productive within a hospital environment so that things can happen quicker, things can be found quicker. And then there's a major cost angle here. You know, let's not forget that the NHS, you know, loses around 8 to 10 billion a year, wastes 8 to 10 billion a year in over-ordering assets, pharmaceuticals, drugs, losing items, and they need replacing. And we have a major role to play in mitigating that. So we have an interest from the commissioning board and certainly around the CFO and the finance directors who need to make a dent there, both on the cost saving side and on the productivity side.
Okay, thanks. Have any of you found any challenge between the two ends of the spectrum, between trying to hit the data needs that have an immediate impact on the patient and at the same time trying to demonstrate the long-term return on investment of your solution and its system-wide impact? Is there any tension ever between those, or do they just fit together fine as bedfellows?
I think they fit together because ultimately the immediate gains for the patient mean either timely detection of deterioration and swift treatment, which prevents further complications, proactive care at home, which means keeping people as well as they can be. Obviously, we all age and the machinery starts failing progressively on different aspects, but it's about keeping people as well as they can be kept and being proactive about it. So I think those immediate gains for the patients and self-management and learning about one's own disease and what makes you better, what makes you worse, and how to manage those are the immediate gains which build up over time. And in some cases, for example, we run one virtual ward with people who are frequent users of 999. They're extremely vulnerable people. Those people usually call 999 because this is their first choice of treatment. And we've instituted a virtual ward, and you start seeing savings and gains within days. Because the moment you prevent 1999 call out and you treat it differently, you have immediate saving for the commissioners, and you have immediate impact in terms of the resource use, ambulance availability locally, which means knock-on effect on the time to wait for other cases, etc., etc. So in different scenarios, the savings for from the larger perspective can build up fairly swiftly. In other cases, because our platform is disease agnostic, in other cases, on other pathways, they build up over time. But there's always a gain to be had. So I don't think there's a conflict between the two. And listening to Simon's description of asset management, we do use the old-fashioned barcoding because for our needs that's good enough. But we know that we had really high compliance rates on patients returning hardware after they used it. But we've heard from clinicians on previous projects, they had 25% attrition rate on the hardware given out to patients to use at home. So there is definitely a challenge, and it is a problem. And sort of when you talk about multi-million-pound investment in a piece of equipment, then it's a fairly big dent in a budget to lose it. But I don't think there's a conflict there. I think it's sort of a natural progression that gains for the patients should translate into gains for the system, because ultimately the patient doesn't get worse and doesn't require hospital admission, doesn't require complex care.
Okay, thanks very much. I'd like to just change tack a little bit and talk about, we talked a lot in the first session and this about digital solutions effectively that were provided, but we still live, and Eva, you gave a very good description of the fact that not everybody can access it, but let's give it to those that can and free up the resources for those who can't access digitally, and if we can then focus on those who have real needs. But there are still challenges around digital access, digital inclusion, the infrastructure required. So the service that you just described relies on the connectivity infrastructure that is out there. So what are the digital inclusion and the digital infrastructure challenges that you're seeing? Are you able to deliver all the services everywhere you want? Or are you seeing that actually the access to the data and to the solution itself is hindered by both the infrastructure and the skills and capabilities of people in digital?
Shall I take that one very quickly? From our side, we're lucky in that we bring our own infrastructure to the provider, to the healthcare provider. So as we all know, in many hospitals around the country, Wi-Fi is very poor. So we just don't rely on hospital IT infrastructure at all. We bring our own network and we use our own bespoke network. That helps for a number of reasons. Firstly, security. We can keep the data very secure with our own cloud services, which are industry standard, and the data is always owned by the healthcare provider. So we're not reliant on Wi-Fi and all the weaknesses that Wi-Fi has, both in connectivity and security. And it just means that we can do a lot more innovative things because we can use other technologies. We use a lot of artificial intelligence to really pinpoint items in a building. We use Bluetooth technology, which is very good again within older buildings with thick walls, and you have to be able to have the signal very widespread around an estate. And then on the remote patient care setting, we utilize a number of 2 to 5G spectrum connectivity protocols and also GPS. So we can mix and match the right connectivity solution based on what the provider needs, rather than just using, bog standard internet, which has many weaknesses.
Okay, thanks, Simon. Just a point on that. So there was a conversation in the earlier session about simple red and amber signals to help the user, really get to access the solutions really easily and simply, and to understand when something is needed to happen. Do you have the same sort of challenge for you? Is the user a literate user that understands all the data that's coming at them from your solutions, or do you have skills and motivation challenges of using the data that you're able to provide?
So from us, we are just tracking the assets. So we do all that work, and all that data is then sent to a dashboard. So it's a very simple interface where, for example, recent studies have shown that 10% of nurses' times and doctors' times is spent trying to find stuff. So if they just pull up their smartphone or go online on their laptop and they see a visual picture, we simplify it as much as possible. We're not giving them a string of data. It's done in a pictorial way, and the same with the patient. So, you know, most of the time, the patients don't need to see our data. It's the provider that wants to know, okay, we know that that patient is using that piece of equipment in that room in their home, or they've taken it outside of the home and it's being transported to another area, which will flag an issue with the provider as well. So it's the provider that's looking at the data. We make it as visual and simple as possible.
Okay, so different for Iggy and Eva, because the patient does need the access, connectivity, don't always have the benefit of it comes with Simon's 2G to 5G solutions bundled in. So one of the challenges that you're seeing about people accessing your solution, and are there any other usability issues that you're coming across too, their skill and motivation issues?
We tend not to rely on Wi-Fi either, and security in data processing and in how we construct our software and how it's rolled out and deployed, and who has access to actually see the data in any scenario is very tightly controlled. And certainly one of the challenges, and I think Iggy can speak to that as well, is connectivity within the building of a care home. So it's not just connectivity at location as such, identified, because you can say, oh, this care home is really well connected, yes, within the office. Then you go outside of the office and it's, you know, a different story. And that's where 5G really kicks in. And we are sort of seeing the impact of 5G in terms of being able to provide a sort of really capable of data transfer, which can allow many different solutions and many different devices to be plugged into and transferred instantaneously, including very rich data sets from imagery, etc. So we're certainly seeing 5G as one of the solutions that overcomes the infrastructure challenges we encounter on the ground. When you're looking at deployment at scale, when you are looking at a population level deployment of a digital solution, invariably you end up with a bring your own device, people using their own smartphone type of solution. And that's where you encounter the health inequalities and digital divide, because the very people who need this kind of support the most are the ones who are not likely to have smartphone, who might not be able to afford the data allowance to be purchased every month and have other challenges. So it's as a supplier for us, it's about working with the care providers, working with the stakeholders on the ground very closely in the setup, in the definition and setup stage, to overcome any connectivity barriers. And it is possible. It just takes a lot of really good planning and mapping out before you do anything in terms of what the possible challenges may be and how you can overcome them. But it's not impossible.
Okay, we've got about 1 minute before I open it to questions from a broader attendees. So, Iggy, is there any last thing that you'd like to add to that?
I was just going to add, because we spoke earlier on about the data requirements of the various healthcare organizations and the NHS organizations in particular. And I just thought I'd quickly chip this in, that in terms of the data that's collected, yes, sometimes the organizations are focused on cost savings and they're thinking about, you know, sort of raw data that shows that there's been a cost saving or that this has been efficient. We've had a few CCGs who said, well, hang on, at the start of this, when you started the project, the doctors or the care home staff were using the device, you know, like 2-3 times a week. And then now they're not using it as much, or they're not using it as often as before. So it's probably useless. And, you know, we then had to explain to them that what's happened is that, one, their confidence levels had increased because they had used the device, they'd been working with clinicians. And so their confidence levels in managing patients had increased so much so that they knew when they needed to escalate. And all of a sudden, they weren't needing to use it quite as often as they did previously. And so it depends on the kind of data that you're looking for and looking at how you can, you know, explain that data to the commissioners so they understand. And I think Eva mentioned earlier on, I think the key, if you look at how often these care home staff are having to call emergency services, I think usually that will tell it all. If all of a sudden that has reduced, it may well be because their confidence has increased and also because they're managing the patients properly, they're monitoring them properly, and so the emergency need or emergency usage has dropped significantly.
Okay, thanks all of you. I wanted to get to a point of saying a brief sentence from each of you on where you're heading as a company in the future and how some of what we've talked about is relevant to that. But quickly, before I do too, can I I'll hand back to Dinah and ask if there have been any questions that we can pick up on quickly in the discussion channel.
Hi, Adrian. Yes, thank you. Okay, we've got a question from Nicola Sutherland. She is asking, how have data privacy issues affected your solutions?
Anybody want to pick up that lovely challenge?
I can answer it very quickly. That in terms of information governance and data, we are defined in our contracts as the data processor. So our responsibility is to ensure that the data travels safely from A to Z. In addition, obviously, we supply our solution, which is the tool for gathering that data. So again, it's about optimizing it so that the data is actually generated. It's being fed by whatever actions, either the vital signs monitoring or the questionnaire answer or communications from the patient to clinicians, vice versa. So in terms of data security and privacy, we are bound by very stringent standards in terms of being a supplier. Our software is a medical device, so there are very, very stringent standards we have to adhere to. And those are being progressively increased by the guidance from NHSX. We've passed DTAC, which is the latest introduction to ensure that data is safe with the suppliers. So certainly, when it comes to information governance, it's one thing which really doesn't cause us any lost sleep.
Thank you.
Great. Thank you. Can we squeeze in one more?
Yeah.
Okay, so from Kirsty Wright, she is asking, what other data-related challenges have we missed? So what are areas of concern for you?
I mean, if I can just add that in terms of what we miss, well, not what we miss, I think there's work going on with this. I think what would be useful, and this is just, again, this is my own little pipe dream, if you like, is that for data to be, for patients to be custodians of their own data. And we know how fragmented the NHS is. And currently, you know, sometimes you have a patient who's living in Edinburgh, for example. I mean, if they had to go and if they required any emergency health care, if they had any emergency healthcare needs, the challenge of integrating that data, of getting data from Edinburgh, can be astounding. And I think what would be useful is if the individual patients are there like custodians to their own data, and they can provide that data to any clinician at any point of need themselves. And I think there's work going on in this regard, but that's probably something that
So
I think
that's part of the interoperability challenge and the data availability to support that interoperability that Eva talked about in the first session.
There's a bit more to that, Adrian, because a lot of places are now pushing, and NHSX is pushing in its guidance for establishing shared care records. And the best version of shared care records, as an exemplar you can see, is, for example, Greater Manchester, where they have a multi-feed of data from not just healthcare and social care, but also the capability to feed multi-agency data from the police, from other agencies. So, for example, if you have a child who is constantly presented at A&E, there isn't that child will not fall through the cracks because the clinician treating them doesn't know that there are various other things connected to this individual, and they can flag up, oh my gosh, this child has been here 25 before, and there's this and there's that, there's the other, and there's immediate trigger going off to the social services and police. So the shared care records is something that is being actively pushed in what good looks like by the NHSX, as that this is what the integrated care systems should be aiming for, this sort of shared vision of the records. And then you don't get this thing where a patient has to go and repeat the same story 5 times over because they happen to be handed over to a different level of care, different agency. So that would be the sort of, I think the ambition is to have this shared access to a single data set that EG is referring to, that will be facilitated by shared care record suppliers.
Thank you very much indeed. That's a great thing to end on because we've just passed the 11:30 cutoff. So thanks again to all of you who have contributed to the discussion and all of the attendees who've joined us. I'll hand back again to Dinah.
Thanks very much, Adrian, and all the panelists. On behalf of Highlands and Islands Enterprise, thank you to our panelists for a great session today, and a final big thank you to everyone who came in to join the webinar. At the end of the webinar, our post-event survey will pop up. If you have a couple of minutes, we'd really love your feedback. Thank you very much for your time today, and have a great day.